That's exciting. I can make it really an hour and a half.
So I just want to get started. I have the pleasure of introducing Dr. Miller, who has recently become faculty in the Colorado School of Public Health. However, she is not a stranger to Colorado nor to the public health field, as she was the state epidemiologist up until coming here officially, and had run the Communicable Disease Division at CDPHE. So we are very grateful to have her not only at our school, but also talking with us today, because her extensive experience, I hope, will inform everybody and provide a very interesting talk. So thank you very much for coming.
Thanks for having me. I'm going to talk about the Emerging Infections Program as an example of applied public health. And if any of you, after I'm done, still want more of the Emerging Infections Program, I'm going to refer you to this journal edition. This is the September 2015 edition of Emerging Infectious Diseases, and it was really devoted to the Emerging Infections Program. It was their 20th anniversary, and so they were able to kind of hijack the whole journal. And many of the articles in the journal are about EIP. So if you want to go more in depth about anything that I'm talking about here, this is a good place to start. And obviously there'd be lots of references on all these articles. A lot of what I'm going to talk about is coming from this journal edition. So just as a reference. As I go through, if I need to clarify something, please ask me about it. But I might ask you to hold more in-depth questions to the end, just so I can make sure I get through most of what I intended to get through. So let's start at the beginning and a bit of the history of EIP. So the history of EIP really started in the early 90s, and there was this Institute of Medicine report in 1992 that was about emerging infectious threats. And they were pretty concerned. They thought that we really weren't doing enough to address emerging infectious threats. And so CDC developed this plan, and part of CDC's plan was to develop the Emerging Infections Program. The concerns were that we were seeing new diseases. There was the thought that we will see additional new diseases. We had seen hantavirus. There's always a concern about pandemic flu. We had seen HIV appear in the relative recent past. There was concern about social changes, economic changes. So daycare use had changed. Food processing had changed. Where our food comes from. A lot of international food distribution was a concern. International travel was becoming more and more common. More and more individuals were being treated with immunosuppressive to treat their condition. And then there was a concern just about enough of a public health infrastructure to actually do the kind of surveillance that we needed to do to understand emerging infectious diseases. There was also concern about drug-resistant organisms like strep pneumo, tuberculosis. So EIP was formed in these sort of four general categories. That the focus was to do enhanced surveillance, and by enhanced surveillance I mean complete surveillance and the collection of relevant epi and lab data, to perform applied public health projects as needed, to implement and evaluate prevention and intervention projects, and then to be there in case something happened that we didn't expect. So to be this flexible response, thank you, Ellie, to be this flexible response to an urgent issue or an emergent issue as they arose. So that was the idea in the early 90s. Not all of these sites were funded right away. These are the 10 sites that are today funded for EIP, and Colorado's among them. Colorado was added rather late in the series of states. We were added in 2000. I think there were 4 originally in 1995. But you can see in the dark green, these are the states that are funded under EIP. One of the core things about EIP is it's this collaboration between state health departments and academic centers. That looks different in different states. Some, it's a very, very collaborative relationship. They basically split funding. They split the projects. Colorado is more on the other end of that collaboration. And I think in Colorado, it's kind of a case-by-case basis. So as projects come up that are really more suited to an academic center, we try to partner with academic centers. So the academic centers for the states that are currently funded are Oregon Health Sciences University, University of California School of Public Health Berkeley, University of Colorado, University of New Mexico, Rochester in New York, Yale School of Public Health for Connecticut, Johns Hopkins for Maryland, Vanderbilt in Tennessee, and Emory and the Atlanta VA in Georgia. The size of these programs in each of these states also varies quite a bit. It ranges from about 22 FTE to 58 FTE that are funded between both the state health department and the academic site. This is a diagram that comes from one of these articles in that journal that I mentioned. It's a little hokey diagram, but actually I think it does a really good job of really telling the picture, giving you the picture of EIP. So it starts with the roots. So you've got the IOM report in 1992 that sort of develops EIP. And then you've got the trunk of this tree, which is the core, and that's this combination and this collaboration between CDC, state health departments, and academic institutions. And then the core activities, again, part of this trunk, are surveillance and applied research. So, pretty good analogy. I didn't do this. Somebody at CDC came up with this, but I do think it's pretty good. The bottom four branches are really the main projects in EIP, and those are the things I'm going to talk about during this talk. Those are ABCs, Flu ServNet, healthcare-associated infections, and FoodNet. So these are separate projects, separately funded projects, and I'll go through and explain what happens in these projects a little bit more. If we have time and you want to ask some questions about some of the top branches, we can do that. As we go, we'll talk about some of the fruits of the tree. You can see the basket of fruit there. Those include prevention guidelines, vaccine recommendations, and vaccine formulation decisions. So we'll touch on some of that as we go through. So before I launch too far, just acknowledgments and qualifications. So this is obviously a long-standing program. It's been in operation almost 22 years. It's 10 states. I have this small view of EIP. I was PI for 4 years, and I was in one state. So just understand, as I'm talking about EIP, I'm going to talk about things that have happened that I really have no connection to, but I think are really good examples of the work of EIP. And I am certainly not responsible for hardly any of this in my short time. There's a lot of people involved, and even just at the State Health Department in Colorado, at CDPHE, there's leadership in EPI, there's leadership at the lab. Each of those projects has their own leader, so there are many, many people involved. So what you're going to get is an overview and a biased sample. So to begin the sampling, we're going to start with active bacterial core surveillance, or ABCs. And that really involves surveillance of invasive disease. So this has to be disease or the pathogen identified in a sterile site due to group B streptococcus, Neisseria meningitidis, strep pneumoniae, or strep pneumo, Haemophilus influenza, Bordetella pertussis, and group A strep. I'm not going to talk about all of them because we don't have time, but I'll hit on a few of them. So basic surveillance methods. This is true in ABCs. It's really true for all the different projects. This is the basic methodology for EIP, for active surveillance. So the attempt is to identify all cases of that invasive disease and collect all the relevant EPI and lab info that is available. So that EPI info comes from medical records mainly. Sometimes patients are interviewed to get information when that's needed. And then the laboratory information is an attempt to actually get the isolate of whatever pathogen is of concern and characterize that pathogen. That may include things like serotype, serogroup, resistance patterns, virulence factors. That is really changing now with whole genome sequencing. So now EIP is really going to sequencing as opposed to microbiologic characterization, which used to be the norm, but that's in transition. And we'll talk about that a little bit. So the lab world in EIP and actually in public health is changing pretty dramatically. So let's start with group B streptococcus. What are we trying to do with group B? So one of the things with these bacterial pathogens is vaccine, right? The holy grail of prevention is vaccination. Right now, there isn't a vaccine for Group B strep, but there's some in development. So one of the things EIP is trying to do is develop that evidence base. So what's the burden of disease? Who should be targeted for vaccine? And also then to have an infrastructure so that if there is vaccine that's licensed, we have an infrastructure to evaluate that post-licensure performance. So that's part of the structure of EIP. We're trying for Group B strep to characterize and understand this rise in adult disease. You can see this graph is for adults. This top line is 65 and older, and then the next line is 50 to 64, and you can see this rise in Group B strep, which we don't fully understand, but that is one of the efforts in EIP is to better understand that. And then the second area where I think there's been more impact is really around infant infection. So for Group B strep infant infection, there are really two different kinds of infant infection. It's divided into early onset, so newborns up to 7 days, and then late onset, after 7 days up to 3 months. There were some early consensus guidelines and ACOG and AAP guidelines that guided providers about prophylaxing pregnant women to reduce this risk of early disease. And you can see in this top line with the squares, the rate of early disease dropped dramatically. So huge success with early disease. And some of that was, and some of the monitoring of this impact was EIP. So that came from our surveillance to monitor the impact of these guidelines. However, even in the early 2000s, there were still a couple options for intervention. So you could screen everybody, you could culture every pregnant woman, and if they were colonized with Group B strep, you'd treat them. So the universal screening approach. And then there was the risk factor-based approach. So you could just look for women who had risk factors. So did they have a fever? Did they have early rupture of membranes? Did they have some risk factor that put them at risk of their infant developing this early onset Group B strep disease? And it wasn't quite clear which was better. So EIP did a cohort study sampling from about 600,000 women across 8 sites of EIP. Colorado wasn't one of those at the time. And compared those two different methods, universal screening versus risk factor-based. And it turned out that universal screening was about 50% more effective. So even though we had come down quite a bit and rates were lower, after this study, the recommendation came out for universal screening, and rates continued to drop. So that was, I think, a big EIP success story. So moving on to Neisseria meningitidis. This is a bacteria for which we do have a vaccine. So that is good. So again, ABCs is trying to understand the trends in Neisseria meningitidis, molecular epidemiology, evaluate vaccines, and look at risk factors for disease. One of the issues with Neisseria meningitidis, it's a good issue to have, which is that rates have dropped pretty dramatically. Not all due to vaccine. Some of this is due to vaccine. But we have such low rates right now for Neisseria meningitidis that it's actually hard to do these studies because there just aren't very many cases. The good problem to have. But EIP did contribute to the vaccine recommendations. So one of the studies EIP did was to look at the duration of protection of that meningococcal conjugate vaccine. There's a conjugate vaccine that covers 4 different serogroups for Neisseria meningitidis. And there was a recommendation that be given once to all 11 and 12-year-olds. That was in 2005. It wasn't clear whether or not there was a booster that was going to be needed, and they needed some more information to help guide that decision. So EIP conducted a case control study 2006 through 2013, looking at that duration of protection of meningococcal vaccine, and found that it did wane. So starting at 3 years after vaccination to 8 years, the effectiveness dropped over time. That information was fed back to the Advisory Committee on Immunization Practices, which is the national committee that sets immunization recommendations for the United States, and that helped them decide to add a booster dose. So after, I'm not sure what year it came out, but after this came out, there was a recommendation to add a booster dose at age 16. So there's an example of EIP data actually feeding into vaccine recommendations. So this last example is about strep pneumo, or invasive pneumococcal disease. So I think this is a really interesting story. Maybe some of you know this story, but the pneumococcal vaccine story is an interesting one. So in 2000, there was a conjugate vaccine licensed, PCV-7, so pneumococcal conjugate vaccine that covered 7 serotypes of pneumococcus, the most common serotypes that cause disease. So that was licensed in 2000. It was recommended for all infants, so infants 2, 4, and 6 months, and then another dose at 12 to 15 months. It was incredibly effective at preventing invasive pneumococcal disease. So rates among that age group for which that vaccine was recommended, rates among young children dropped dramatically, as expected. But what was not really expected was this fairly dramatic drop in adults as well. So the vaccine was licensed in 2000, and immediately you see this drop in 85-year-olds, 85 and older. These other drops, although they don't look quite as dramatic, were also significant. I think the percentage ranged from 35% drop to 19%, depending on that age group. So even in adults who weren't getting the vaccine, they had this protection because the vaccine was preventing carriage in the nose and throat of these children, and so there was just less transmission of pneumococcus disease. So that was a huge benefit of vaccine, and a somewhat unexpected benefit, and they actually had to redo the cost-effectiveness calculations because the calculations that they based it on turned out not to be correct because it was more effective among adults than planned. So great. But then what happened? So then this graph demonstrates changes in serotypes of pneumococcus that aren't in the vaccine. So these serotypes, you see them listed here, 3, 6A, 12F. I don't know how they come up with the numbers and the letters, but these were all serotypes not included in PCV-7 that changed after the introduction of PCV-7. So if you remember, PCV-7 is introduced in 2000. These years cover 1998 through 2004. And you can see, in some cases, they actually went down, but some of these are going up. 19A in particular is going up, and you see these are the highest rates are attributed to 19A. Some of these others go up a little bit, and you can also see that they go up pretty quickly. So this other vaccine is licensed in 2000 pretty quickly. You see these non-vaccine serotypes increasing. The top set of graphs is kids less than 5, so what you'd the population among whom you'd expect to see this, that's the vaccinated population, right? But then also the bottom set of graphs are adults greater than 65. So you see the same thing in adults. Again, even though this isn't the group that's being targeted for vaccination, they're seeing the effects of this serotype distribution and transmission. So we have serotype replacement. So we've covered these certain serotypes in the vaccine, but now we've got other serotypes moving in. So what do? You introduce PCV-13. So PCV-13 was introduced to cover those serotypes that had seen increases, in addition to the 7 that were already in PCV-7. That was introduced in 2010. And again, these graphs show the results, and all of these data that I'm showing you are coming from EIP. So EIP demonstrated that the rate of invasive pneumococcal disease in kids less than 5, again, drops dramatically. The top line, this top dark blue line, is all invasive pneumococcal disease. Yellow is just serotypes in PCV-13, and then green is serotypes not in PCV-13, which stay about the same, which is good. We don't want that green line to increase. So among kids who are the targets of vaccination, you see this dramatic decrease. And among individuals 65 years of age and older, you also see a decrease. So same thing happened. We see this effect in the population that wasn't even targeted for vaccine because we're just reducing carriage and transmission in the population at large. The next part of the story is PCV-13 in adults. So now there's a recommendation. Before there hadn't been a universal recommendation. I think it was late 2014, there was a recommendation to give PCV-13 now in adults 65 and older. But the committee said, the Advisory Committee on Immunization Practices said, we're not sure we need to continue that recommendation because maybe just vaccinating kids will make the rates go down enough in adults that we don't really need a vaccine recommendation specific for adults. So what EIP is doing right now is trying to evaluate the impact of PCV-13 in adults. That's the work that is ongoing right now. So moving on to another pathogen, pertussis. So pertussis is an example where the state health department in Colorado, at least, works with local health departments to do this EIP project. Because for pertussis, local health departments are calling up patients and doing disease control work and gathering information anyway. So it makes sense that we kind of combine these activities with the regular disease control activities. So we fund local health departments to help us collect information about pertussis. Pertussis is also something that was added later in the evolution of EIP, only in 2011. And that was because we were seeing this huge increase in pertussis, as I'm sure everybody recognizes. It was an issue, and it was thought that we could collect some better data and get a better picture and a better understanding of what was happening with the increase in pertussis if we added it to EIP. I should add that we do this work, at least in Colorado, we do this surveillance work under public health authority. So none of this surveillance work is considered research. It's all considered public health practice. We sometimes do cohort studies or case control studies. Those are considered research, and we go through IRB. But for routine surveillance, it is not considered research. So this is just an example of the added benefit of EIP. So in this graph, EPS, the dark bars, stand for Enhanced Pertussis Surveillance. So that's really the EIP pertussis surveillance. And NNDSS is the National Notifiable Disease Surveillance System. NNDSS is just the standard surveillance that every state does. So pertussis is a reportable condition in every single state. Everybody's collecting information about pertussis. So why would we need to do it in EIP? So this is an answer to that question. So this is the number of the rate of disease of pertussis by age group. And you can see for each age group, the rate in EPS, or Enhanced Pertussis Surveillance, is greater than the rate among NNDSS. So basically, it's more complete. We're doing a better job at getting case reports and identifying cases. This is data about the characteristics of pertussis cases. So this is some epi data, race, ethnicity, symptoms, whether or not somebody was hospitalized, and their vaccine history. And you can see in Enhanced Pertussis Surveillance, again, it's very complete. We're aiming for 99, 100% completeness. It's not that complete for every variable, but it's consistently higher and more complete than the National Notifiable Disease Surveillance, or the standard surveillance. So what does that allow us to do? I think Oregon has done a good job at taking advantage of the completeness of data, and they've published several studies. These are a couple of them. So for one, they looked at risk factors specifically among Hispanic infants, and they were able to do that because they had this great race ethnicity data. Usually in public health standard surveillance, race ethnicity is really difficult to collect, and we don't usually do a very good job of it. But with Enhanced Pertussis Surveillance and with EIP, we can do a little better job. They also looked at the impact of vaccine and how that reduced severity in pertussis. And again, because they had really complete data about all of the characteristics of the case and their symptoms, they were able to do that reliably. So another thing that I think pertussis serves as an example for is what you can do with whole genome sequencing. This is also a real challenge with pertussis, because if you know how pertussis is diagnosed, anybody? PCR, right? It's not, people are not culturing pertussis anymore. They used to, but probably 95% of pertussis is PCR. So there actually is no isolate. There's a specimen, and they've done a PCR test on it, but nobody's growing anything with pertussis anymore. So one of the things that EIP states do is try to collect those isolates. So in Colorado, for instance, we work with Children's Hospital and we work with Kaiser, and we ask them to give us all their PCR positive specimens. So we say, stick them in some media, send them to us, and we'll grow them at the state health lab. And then we send those to CDC, and then CDC does the whole genome sequencing. So actually getting the isolate is a problem sometimes, and EIP can serve as a source of isolates. And this map of the US just demonstrates where CDC's isolates come from. You can see the dark red states are EIP states, and those circles represent the relative number of pertussis isolates that state is sending. So states with the biggest circles are sending the most isolates. So Minnesota, Colorado, I'm proud to say, Oregon, New York, those are all EIP sites, and those are sites with bigger circles. The different colors in that circle represent basically different genome structures of those isolates that are being sent. So the other thing this demonstrates is that the structure of pertussis varies geographically. You can see that circle is made up of different colored pieces of pie. So you see quite a bit of variation in the genome structure geographically. And then this other pretty graph over here, or figure, I guess, that's a representation of the actual genome structure of the Bordetella pertussis organism. And these have different names. Hopefully what you can see on here is that the patterns of these segments are similar from genome to genome, but they're in different places, or they're inverted. So there's a lot of structural rearrangement of the pertussis genome, which again was somewhat surprising. A surprising finding to find that there's this much structural rearrangement in pertussis. The bottom line that you see there, this one here, is actually the vaccine strain. And it's still the vaccine strain that's used. And you can see how different that vaccine strain is than the other genome structures. It doesn't mean that the vaccine is not effective. It is effective. One of the issues with pertussis, again, similar to the meningococcal vaccine, is that protection wanes. So still more work to do to understand what the implication of all these genome structural rearrangements is, but really some fascinating data that's coming out of whole genome sequencing. All right, going on to flu. So flu was added again, not one of the first pathogens that was involved in EIP. If anybody remembers 2003, 2004, that influenza season, it was horrible. It was a very severe season, very severe for children. We had 12 pediatric deaths in Colorado, and it really alarmed people. And so that's when EIP started this flu ServNet, or influenza surveillance network. Again, to really understand what was happening with influenza a little better and get some better data about influenza. This is just hospitalized influenza, so it's only cases who are hospitalized and who have a positive test. And in this case, we added some sites, so it's not just those 10 EIP sites. There's some additional states that just do flu surveillance, so it's a little more geographically representative. So one of the objectives is just to look at the weekly rates of flu. And in this case, flu is different than most other pathogens we do surveillance for. Most other pathogens, we don't have real-time data, and we don't put real-time data on the web. We may be looking at surveillance data a year past the date when the data were collected. With flu, we're really trying to be close to real time because it's important. People need to understand what the severity of the current flu season is. So these graphs actually come from the CDC flu surveillance website. If you haven't been there and you like flu, it's a great website. It's interactive, so you can pick a season, you can pick age groups, you can look at all kinds of different things. These graphs look at the rate, and these different colors of the lines are different age groups. So this top green line is ages 65 and older. You can see that's always the highest rate, always has the highest rate of flu, or those people who are older. But you can see how dramatically different it is from season to season. So one season, this rate for 65 and older is way above all the other age groups down here. This season, it's rather low, and these are all the same y-axis, so you can compare them. But this is a good demonstration of just how different flu is every year and how we can use this surveillance data fairly real time to look at what's happening with flu rates. Another thing is to look at the burden of flu and the burden averted by vaccination. Flu is a challenge because we know that if we're just looking at hospitalized flu, we're really looking at the tip of the iceberg, or at least the middle of the iceberg. We know there's a lot more flu out there. There's people who get sick and never go to the doctor, people who go to the doctor but not the hospital. So the hospitalized people are really not necessarily representative of everybody else with flu. And even if you're trying to count everybody who's hospitalized, some people who get hospitalized aren't tested for flu. There may not be a clinical reason to test them. Maybe they are tested, but the test isn't very sensitive. So the test is negative when they actually do have flu. Rapid tests, which are used quite frequently, are poor tests. They really lack sensitivity. And the sensitivity is actually worse the older you get. And people who are more likely to be hospitalized are older. So there's really an issue with the way we do surveillance for flu, and CDC has attempted to correct for that. So they've created these models that adjust for these factors. They adjust for under-testing, and then they adjust for the kinds of tests that are used. And we collect this data in EIP so that they can make those adjustments. They then extrapolate that to the whole U.S. population because, again, these are just 13 sites, but that data is extrapolated to the U.S., and then that data can also be used to extrapolate deaths, and using some other data, not EIP data, they extrapolate everybody with symptomatic illness to really give a fuller picture of flu. And then knowing vaccine coverage and vaccine effectiveness, you can also calculate what the burden might be if you didn't have vaccine, right? If you know how many people are covered and you know the effectiveness of that coverage, you should be able to calculate what would happen if you didn't have vaccine. So then you can calculate the burden that's averted by looking at that hypothetical burden without any vaccine and subtracting the observed burden. So you get this vaccine averted burden. And one of the things that CDC has done with this is do some more public education. So this is translating this EIP surveillance data that's kind of hard to understand, I think, for the general public into some information that hopefully is a little easier to understand. And I don't know if any of you have seen this infographic, but it actually uses Denver to help describe what the impact of flu and the impact of vaccination is. So on the left here, it says the estimated number of illnesses prevented by flu vaccination during the 15-16 season was 5 million, or as many people as used DIA in 1 month. So trying to make it a little more relatable, flu vaccine gets a bad rap because compared to other vaccines, it's not a very effective vaccine, 50 to 60%, probably in a good year. But when you look at that on a population basis, the impact that has is huge. But for an individual, it's really hard to communicate that. So this is an attempt, I think, to do that. This one gives the number of medical visits prevented by vaccination at 2.5 million, or the population of Portland. And then this last one is the number of hospitalizations prevented by vaccination, 71,000, enough to fill every registered hospital bed in Texas. So I don't know if that's a little more relatable, but I think we really do need to do something to try and communicate differently about influenza. So then there's just other uses of the data that we can use to look at vaccines and antivirals and just do descriptive studies of influenza. So there's quite a bit of that with flu. Here's an article looking at the increase in antiviral treatment over time between 2010 and 2015. An article looking at the severity of influenza, and if vaccination decreases severity among those who are hospitalized, Only moderately so is what we found, at least in that analysis. And then flu can also serve as a platform for some other studies. And I wanted to use flu for this example of health disparities. So this is actually going on in other parts of EIP, but this is a good example, I think, where flu has used this data and actually published this data. So one of the things we do with almost all the cases that are under surveillance is we geocode them to census tract. And then once they're geocoded to census tract, we can link to poverty, education, all of those census variables that you all know very well. And then this is just a simple analysis looking at the prevalence by census tract categorized by percent of poverty. So these census tracts here have a low percentage of poverty, 0 to 4. These are the highest poverty census tracts with more than 20% of individuals in that census tract at the poverty level. And then we just look at the incidence by these poverty categories. And you can see that there's this very clear relationship between poverty and influenza prevalence or incidence. And this was true across every state. It's true again across age groups. It was very dramatic. And there's other work that goes on in other parts of EIP, but this was just a flu example that kind of illustrates it well. The other thing that we're trying to do is look at electronic medical records. EIP traditionally has abstracted information. So we may use electronic medical records, but we're going to the medical record and we're abstracting from the medical record onto either paper in some cases or a laptop or a tablet, but it's abstraction. This is a study that's actually trying to just extract that EMR data. There was a study at Yale where they really piloted this, and now we're trying this among more of the EIP sites, 6 sites. And Colorado is working with University Hospital and Children's Hospital. And it's really University Hospital and Children's Hospital who are doing it because the state health department doesn't have any access to their electronic medical records, right? So it's really those hospitals that are working on this. And as you can imagine, I think it's pretty challenging. So there's multiple sites extracting from multiple kinds of EMR records, trying to make sure that all the variables are standardized and can be used in the same way and are comparable. Initially, we're looking at the use of antivirals and diagnoses of acute respiratory infections. So we'll see how this works out. But I think it's a place we probably need to go, and we need to be able to do this kind of work a little better and utilize electronic medical record information. So here's an example of responding to changes. One of the changes that we anticipate in the somewhat near future, I don't know how far in the future this will be, but it's likely that there will be a vaccine for respiratory syncytial virus, or RSV. Right now there is no vaccine, but there are literally dozens in the pipeline. So I don't expect you to be able to read any of this in this bottom square, but this chart is from a website excuse me, called PATH, and they have an updated list of vaccine development for all sorts of pathogens. All of these squares represent some sort of vaccine or monoclonal antibody development for RSV. So there's lots of products. They're aimed at different populations. They might be aimed at older individuals. They might be aimed at mothers to protect babies. So lots of vaccine work going on. But we don't do surveillance for RSV. So EIP is exploring, can we use this thing that we've already developed to do flu and just substitute RSV? Can we just swap in RSV and do this? And they made it sound that simple, and we know it's not that simple, but something that we need to respond to, and there is work going on to see how we can do that. So there's some pilot work going on with RSV surveillance to see how do we develop this platform so that when RSV is licensed, again, we can do that post-marketing evaluation or post-licensure evaluation of the actual impact of vaccine. So let me move on to FoodNet. FoodNet tracks infections transmitted by food. probably could have guessed that, and studies the sources of those infections. Again, it's CDC, the 10 states. In the case of FoodNet, there's some other partners and some other funders of this work. USDA, FDA are also involved. They produce this annual report called the National, sometimes referred to as the National Foodborne Report Card. I'm sorry Elaine Scallon isn't here, because Elaine used to work at CDC on FoodNet, so Elaine is a FoodNet expert. And there at the bottom, you can see the list of FoodNet enteric pathogens that are under surveillance. I'm going to talk about a couple things that are important in FoodNet. One of them is culture-independent diagnostic testing, or CIDT. So CIDT happens all the time, right? We've talked about culture-independent diagnostic testing already. So pertussis isn't diagnosed by culture anymore. Flu isn't diagnosed by culture anymore. Legionella isn't diagnosed by culture anymore, right? We use urinary antigen. So we don't have specimens anymore for many pathogens. This world is just sort of entering the foodborne disease world. So in foodborne disease, they used to just culture everything, and so they always had an isolate. And now more and more, they have these multiplex GI panels that can be used, where you test for multiple GI pathogens in one panel. You get results very quickly, and you can test for a large number of pathogens. It's not culture. It may be PCR-based, for instance, so you don't know that these are live organisms. You just know the organism is there. So it's a huge change for FoodNet, and they're spending a lot of time monitoring this. So they do lots of lab surveys. They want to keep up with what labs are doing and understand the testing that they're doing, because these have a huge impact on surveillance. And you can imagine that. So if you're monitoring trends and all of a sudden there's a new test, and maybe that test is used more by providers because it's easier, it gives providers more information, maybe it's more sensitive, it increases the detection. So there's lots of reasons why it could be implemented more. On the public health end, we don't get as much information from those tests. We don't get subtyping. We don't get resistance. We can't link those together with pulse field gel electrophoresis to tell if there's an outbreak. So huge, huge impact. And you can see this, I'll just look at this example of Campylobacter. These are the number of infections that have been identified in FoodNet using culture-independent diagnostic testing since 2013. So this is just 2013 to 2016. And you can see, for one, just the huge increase over that short period of time. So huge number of culture-independent diagnostic testing done. The light blue box represents cases in which there wasn't a reflex culture. So reflex culture just means that automatically there's a culture done. And that's what we'd like with culture-independent testing. If you get a positive test, we'd like you to just go ahead and culture it. That doesn't always happen. So this just demonstrates that things are changing dramatically, and we may not have this information that we used to have that we got from cultures. So that's a big adjustment for FoodNet and for other surveillance systems as well. The other example I'm going to use with FoodNet is a disease control application. So back in the early 2000s, there was a case control study of Listeria cases. So these were cases reported to public health, sporadic cases. These were not outbreak cases. These were just your single case of Listeria. And it was aimed to identify risk factors for sporadic Listeria. Oftentimes, if there's an outbreak, we figure out what the source is, right? But for sporadic cases, you really can't do that unless you have this kind of study. So they did a case control study looking at risk factors and found a couple surprising things. One was hummus. So hummus here you can see has an odds ratio of 5.74. That really wasn't known before, that hummus was a risk factor for Listeria. And then eating melons, 2.63. Not huge, but that was also kind of a surprise. People really didn't expect that. So what happened after this study was that they added those two things to the standard questionnaire that all Listeria cases get. So if you had a case of Listeria, they'd administer a questionnaire to you and ask you about the foods you ate in the last, I don't know how far they go back, maybe 60 days. But they added these two things. They weren't there before. So now, on all the cases of Listeria, we know the percent that ate melons and we know the percent that ate hummus. Okay, so this became pretty important in 2011. So in 2011, if you remember, we had a huge Listeria outbreak that was centered in Colorado. And we were able really very, very quickly to identify cantaloupe as the source. And the only reason that we were able to do that is because we had this questionnaire data. So we had, for our sporadic cases, we knew the percent that ate cantaloupe here. It was 64%. Our cases, 100% ate cantaloupe. These different dates just represent different analyses that were done as we collected more interview data about food histories. So our cases clearly were eating more cantaloupe than were the sporadic cases that we were comparing to. And so this was very clear evidence that cantaloupe was the source. And this was later confirmed with some actual specimens from cantaloupe, but this was early information that really led us to hone in on cantaloupe, and I think probably prevented illness and probably prevented deaths, because there were quite a few deaths related to this, as well as many illnesses. So last thing I'm going to talk about, and then we should have plenty of time for questions here, is the Healthcare-Associated Infections Project. So this, again, wasn't one of those first things that we did, launched in 2009, and I think was launched because it was recognized that HAIs were a growing issue, and also it was recognized that health departments had a role to play. I think for a long time this was really thought of more as a hospital issue, but really there was a public health role to play and a state health department role to play. And so they added healthcare-associated infection surveillance to the EIP. It includes surveillance for these organisms: Clostridium difficile, Candida, carbapenem-resistant Enterobacteriaceae, or CRE, and Acinetobacter baumannii. And again, we're collecting information from medical records, looking at epi information, and trying to collect the isolate as well, so we can pair that epi and the lab information. The other thing that HAI does are these epi projects. They do several kinds of point prevalence surveys, and they look at antimicrobial use, both in hospitals, and more, they're looking at these issues in nursing homes or long-term care facilities. So again, CDC kind of packages up this information, and in this case, they're packaging it up and they're putting it into vital signs. Who's seen vital signs before? A little bit, not getting a huge distribution. Vital signs are meant to be this relatively brief information that's aimed more at providers and public health professionals, not so much lay people. So it's a little more data heavy. So they use some more statistics. They've done vital signs on C. diff, on CRE, antimicrobial use in hospitals, antimicrobial resistance, and sepsis. And then this is one of those point prevalence surveys, and these tend to get a lot of attention. So this was a one-day point prevalence survey going into 183 hospitals across our 10 sites, looking at the prevalence of healthcare-associated infections, and they found that it was 4%. They also identified the most common types of infections: pneumonia, surgical site infections, GI infections, and the most common infection, which was C. diff. And then I'll just give you another example of laboratory methods affecting surveillance in the HAI world. So this is looking across 3 of the EIP sites at C. diff and how C. diff is diagnosed. So laboratories have been switching from EIA tests, or enzyme immunoassay tests, to nucleic acid amplification tests, a molecular test. And the molecular test is more sensitive, as you might guess. So in this study, they looked at labs who had switched, called switch labs, and they compared the number of cases they'd identified pre-switch to post-switch, and they matched them on months, pre and post, if that makes sense. And they looked at that ratio between pre and post-switch. And then they in the same state, looked at labs that didn't switch. And you can see here that the ratio for these switch laboratories is 1.5, 1.3, 1.6. And for the non-switch labs, there was no change in numbers. So out of this, calculated an attributable increase due to the switch to nucleic acid testing. So ranged from about 40 to 67%. So that's pretty big when you're talking about a change in rate. And with HAIs, that's really important because for HAIs, there's a lot of comparison hospital to hospital. There's these hospital report cards that report on HAI rates. There may be national reporting. There's national reporting for a lot of different conditions. So these test issues, even though they might seem minor, can really impact the rates that are reported. All right, let me spend just a couple minutes on some cross-cutting issues most of which came up, but I want to recognize that these cross-cut across all of these areas. So IT, if you can just imagine the complicated IT in this project, or in this program overall, because you have multiple projects. Even within one area like FoodNet, you have multiple projects. You have 10 different states. Sometimes in those 10 different states, you have 2 different organizations collecting data. You might have the academic and you might have the public health. So just imagine trying to kind of collate all that information and create data systems to manage that information, as data changes as quickly as it does, or data technology changes as quickly as it does. I think it's a challenge anywhere. It's certainly a challenge in EIP. And then health equity, I think I've mentioned. Again, that's cross-cutting. That goes across all these projects. All of the projects are geocoding the cases so that we can look at that census data. Training, I wanted to be sure to mention training since we're in a training environment. So in Colorado, we do a couple things. One, we hire MPH students. So I don't know that we have any here, but one of our faculty used to be a student in EIP. So Tessa was an EIP student once upon a time. And we think it's a great deal. We get great people who really care about what they're doing and are trained and understand what they're doing. So we get a good deal. And hopefully the MPH students learn something about surveillance and about these projects that they're working on. We also provide EIP data for capstones. I know at least one DRPH who's using data from EIP. And then we have these twice yearly EIP partner meetings. So we invite the laboratories at the hospitals who are doing the lab testing, the infection preventionists at hospitals who are reporting this data to us, local health departments who are helping collect the data, several physicians from especially Children's and University Hospital come to these meetings. And we present on the latest data. Sometimes it's our partners presenting on their latest data. Not always EIP. It might be some other emerging issue that we think people would be interested in. And this has always been an EIP goal, but I like the word effervescent. It's not a word you use or I hear that much, but in the September 2015 journal, there's an article about training, and that word is used. The funding has never really been dedicated for training. I think it's been something that people have done because they want to do it. So some sites are a little more effective at this than others because you have to be a little creative about how to do it. And then whole genome sequencing. Again, really revolutionizing the public health lab world and is really going on across EIP, not just the example that I gave you. So what are the ingredients for success? One of the things EIP tried to do, because I think this is considered very successful by the states involved and by CDC, is they tried to expand it to non-infectious disease areas, and they did a little pilot. And we did a little opioid project. Other sites, there was a spina bifida project. There were some other projects that were attempted, and it was fine. But I don't think there's really magic in EIP. I think if you have a well-funded program like EIP has been, that's a priority for CDC, so that is consistently funded. And you have this long-term relationship, which EIP has. There's a lot of trust that's developed. EIP basically works on consensus because I think people do trust each other and are able to give their opinions and debate issues and come to an agreement that people can live with. And you have this network of public health departments and academic centers. But I think if you applied those ingredients to really any subject, I think it would be successful. But this has been applied for over 20 years to infectious diseases, particularly emerging infectious diseases. And so I think it has been successful. But I think you could do the same for chronic diseases. You could do the same. And there probably are examples of networks that are longstanding networks that are also successful. But I don't think there's some little magic bullet. I think it's just basic long-term investment. So I want to just end by thanking, hopefully I've listed all the people in Colorado here who are part of EIP. I'm sure I've forgotten somebody. But these are people who've worked for EIP in Colorado over the years and have been part of this work that you've seen. So thank you very much. Questions?
So with the pertussis, now that the whole genome sequencing is going on with pertussis through PCR, sort of through PCR, is there any, because there are only a few states in the EIP system, is there any relationship that you guys are seeing, or is anyone investigating a relationship between these genome profiles and percent vaccination rates within the states? Because the states differ with their percent vaccination. Right. Is there any relationship, or has anyone looked into a relationship between vaccination, the percent of the population being vaccinated, and which genome profiles are really popping up in those states? Does that make?
I don't think they've looked specifically at that. I mean,
Okay.
one of the issues with pertussis has been pertactin. So pertactin is an antigen that's part of the organism. It's also included in the vaccine. So it's something that the body makes antibody to. And what EIP has documented partly through the sequencing is that pertactin has gone away. And people who are vaccinated are more likely to have pertactin deficient Bordetella pertussis. Okay. So there is this vaccine pressure that influences the kind of pertussis you're going to get infected with. But in this case, it didn't seem like it affected the clinical presentation at all. So I don't think there's been work specifically on that question, but
that got it.
But people are looking at that issue, and I think there's just a lot that could be done, and they're just kind of starting. Yeah. Yes.
I'm curious about foodborne illness and estimates of the roles of houseflies in the transmission of foodborne illness.
Houseflies?
In other words, how freaked out should you get if a fly lands in a potato salad when you're on a picnic? The role of flies in foodborne illness.
I don't think EIP has addressed that. I guess just from my communicable disease experience, it's not a risk factor that we think about with foodborne disease. I mean, the things that we think about and the things that cause most foodborne disease are holding food at the wrong temperature, so not keeping it cold or not keeping it hot, hand washing, so food getting contaminated by a person, or cross-contamination. So your raw chicken contaminating your salad. So there might be some research out there. I'm not.
I hadn't seen it, but everybody freaks out. Housefly.
I don't.
There's a lot of species in that area, then maybe.
We also have the 5-second rule at our house. So if something's on the floor and you pick it up, it's fine in 5 seconds. Yes.
Great, thank you. This is a great talk. I had a question about the Group B strep surveillance targeted versus universal screening surveillance study that was done by EIP and how they found that universal screening was more effective than targeted. And I think that's just fascinating because you think about like STDs. Typically, we do targeted screening for STDs, and that's the main move now. The push is towards targeting screening, not necessarily for USPSTF screening guidelines, but for some of the for some of the organisms that we're seeing an outbreak, and so we try to determine what were some of the risk factors that we could have looked at. So why is it that you think that it was universal screening was more effective?
I don't know. That study was before my time. The risk factors weren't identifying everybody. Basically. So you were missing people by only focusing on the risk factors. And I don't know to what degree people were actually implementing the risk factor strategy. So I think it's probably easier just from a workflow standpoint to make sure that everybody's cultured versus did you screen them, and then if they screen positive, did you treat them? I don't know. Yeah. Other questions? All right. Thank you very much.